All right, let's talk about pediatric atropine. We're going to do a super quick 5-minute guide on this. By the end, you'll know exactly how to dose this critical drug safely, especially when the pressure's on and every single second counts.
Okay, so you're in the thick of it. You've got a pediatric patient with bradycardia. Heart rate is dropping. You know you need atropine, but what's the dose, right? It's one of those questions you have to get right instantly.
And here's the thing, it's not just one simple number. There's a bit more to it. We're talking about some really important guardrails. Think of them as a floor and a ceiling for your dose, and you absolutely have to know them to use this drug safely.
So, let's kick things off with Section 1, the core formula. This is all about getting that dose right every single time.
Okay, the number you need to burn into your brain is this, 0.02 milligrams per kilogram. That's your starting point. Pretty straightforward, right? But hold on, that's just step 1. All right, this here gives you the whole picture. So yeah, you start with 0.02 milligrams per kilo. But, and this is a big but, it's sandwiched between two hard limits. You can never go below 0.1 milligrams, and you can't go above 0.5 milligrams in a single shot. Oh, and you only get one repeat. Seriously, these boundaries are just as critical as the calculation itself.
Okay, on to Section 2. We're calling this the minimum dose paradox, because it's all about why giving less can actually be dangerous. We really got to dig into this minimum dose thing, because getting this wrong can lead to a really bad outcome.
Now you might be thinking, wait a second, that doesn't make sense. You know, for a really tiny baby, the math might tell you to give less than 0.1 milligrams. So why can't we just give that tiny dose? What's the big deal?
Well, the answer is this really interesting and, frankly, critical phenomenon called paradoxical bradycardia. Here's what happens. If you give a dose of atropine that's too small, and that magic number is under 0.1 milligrams, it can actually backfire. It triggers a reflex that does the exact opposite of what you want. It can actually slow the heart rate down even more. And this is what that risk looks like. You dip below that 0.1 milligram floor, and you risk making a bad situation worse. You stay at or above it, and you get the effect you need. The heart rate goes up. The rule is non-negotiable. Never give less than 0.1 milligrams. I don't care how small the patient is.
Okay, Section 3. We're calling this first things first. So now that we've got the how down, the next big question is when. Is atropine really your first move?
And the answer to that is a huge, resounding no. And listen, if you only remember one thing from this whole explainer, let it be this. In kids, bradycardia is almost always caused by hypoxia. It's a breathing problem, not a heart problem at its core.
So what does that mean? It means your priorities have to be crystal clear before you even think about reaching for a drug. Your first, second, and third job is to manage the airway. Oxygenation, ventilation, that's priority number 1. Atropine is way down the list after you've taken care of their breathing.
All right, Section 4, when atropine shines. So if it's not our go-to first-line treatment, then when is it the right tool for the job?
This is where atropine really has its moment. It's most effective when the slow heart rate is due to a primary electrical issue with the heart itself, not from a lack of oxygen. The two classic examples you'll see are increased vagal tone or a specific heart issue like an AV nodal block. That's when this drug is a game changer.
But what if you've sorted out their breathing, you've given the perfect dose of atropine, and the kid just isn't getting better? Or maybe they're even getting worse. If that kid is still unstable, you don't wait around. You escalate immediately. Your next move is epinephrine. And if that doesn't turn things around, you start CPR. Epi and CPR come way before you even think about a second dose of atropine.
And that brings us to our final section, the final takeaway. We've thrown a lot at you, so let's boil it all down to the one single sentence you absolutely have to remember.
Here it is. This is the sentence that has it all. The dose, the minimum, the maximum, and the repeat. You burn this into your memory, and you've got the entire dosing rule right there when you need it. So we'll leave you with this question to think about. You've mastered the dose, you know the floor and the ceiling, you even know the specific times to use it. But just remember that hierarchy. Before your hand even moves toward that vial of atropine, what is the very first thing you absolutely must check?